Well, it looks like we're finally getting some good news on the pain management front. I've said it before, I'll keep saying it. The CDC is an organization of politics, not science, and pain management is actually one of the worst things they've been involved in, creating the most damage for people. But we have a little bit of good news, as elucidated in this Reason article by Jacob Sullum. So they have revised and expanded pain treatment guidelines that are at least a marginal improvement over their god-awful 2016 guidelines. They actually mention patient abandonment 8 times and include 2 occurrences and say in bold and italics, clinicians should not abandon patients. And as we'll see here is kind of a recurring theme. Why would they have to say that? You would think that, clinicians, doctors with their patients, that would be kind of the default. Oh, I'm not going to abandon my patient. But that's what these guidelines do. So, as Sullum says, something has clearly gone terribly wrong when clinicians have to be reminded that they are not supposed to abandon patients. At the same time, the CDC's acknowledgement of the problem signals its willingness to address the needless suffering caused by the 2016 guidelines, which resulted in undertreatment, reckless tapering of pain medication, denial of care, and pro-Crustian policies that prioritize reductions in opioid prescribing over the interests of patients. So, we're talking about opioids being prescribed for chronic pain. We're not talking about like black market fentanyl and things like that. And so they were setting these arbitrary limits and saying chronic pain patients who are already above those limits should be forced to comply with an arbitrary limit that was not based on anything scientific or medical or research-based or anything. They said they also touched on acute pain because long-term opioid use often begins with treatment of acute pain. Lie. Yeah, we've covered why that's a lie. Ostensibly, the guidelines were purely advisory, but in practice, many patients found, to their dismay, they were mandatory. And this is something that it's pretty much a recurring theme. There basically is no such thing as a request or guidelines from government. They have people with guns. Law enforcement says, can we search your car? Well, how do you interpret that? They might be able to get away with it. Well, no, we just asked. It wasn't a warrantless search. We just asked to search their car. Well, yeah, but you don't really feel that, you can say no, can you? So that's what they rely on. So in the new guidelines, the CDC says, some policies that were purportedly drawn from the 2016 CDC guideline have, in fact, been notably inconsistent with the 2016 guideline and have gone well beyond its clinical recommendations. They just didn't understand it. They didn't understand what they were saying because I guess they're dumb. I guess doctors are dumb and they don't understand that when the CDC makes guidelines that they mean something completely different from what they actually say. So all this misapplication, the CDC notes that the FDA has advised that the risks of rapid tapering or sudden discontinuation of opioids in physically dependent patients include acute withdrawal symptoms, exacerbation of pain, serious psychological distress, and thoughts of suicide. Well, at least suicide's getting a mention in. And the CDC is referring to the safety announcement that the FDA issued 3 years ago in response to complaints from patients and pain specialists. Notably, the FDA warning mentioned not just thoughts of suicide, but completion of the act, as we've covered. When patients respond to CDC-inspired medical practices by killing themselves, it might be time to admit that the agency issued its advice without sufficiently considering the potential for unintended but foreseeable consequences. Yes, as we covered, these were very foreseeable. Lots of people were saying that this was going to happen. But the CDC never quite admits that in the new guidelines. They're just saying it's misapplication. They say, This voluntary clinical practice guideline provides recommendations and does not require mandatory compliance. The clinical practice guideline is intended to be flexible so as to support, not supplant, clinical judgment and individualized, patient-centered decision-making. But the new advice does retain a bias against opioid treatment, but, unlike the 2016 version, does not imply that daily doses of more than 90 mme for chronic pain are inherently sus. Yeah. You ask me, the CDC is kind of sus. Maybe we got an imposter among us here. Alright, so this is the CDC. Payers and health systems should not use this clinical practice guideline to set rigid standards related to dose or duration of opioid therapy. And they should ensure that policies based on cautionary dosage thresholds do not result in rapid tapers or abrupt discontinuation of opioids. For patients already receiving higher opioid dosages, clinicians should carefully weigh benefits and risks and exercise care when reducing or continuing opioid dosage. Again, kind of weird that they have to say that, don't they? Yeah, weigh the benefits and risk and exercise care. Isn't that what they should be doing anyway? Is it really their fault, the CDC? Huh? Or is it yours? Is it yours? Because I think it's yours. If risks outweigh benefits of continued opioid therapy, clinicians should optimize other therapies and work closely with patients to gradually taper to lower dosages, or, if warranted based on the individual clinical circumstances of the patient, to appropriately taper and discontinue opioids. Unless there are indications of a life-threatening issue, such as warning signs of impending overdose, confusion, sedation, slurred speech, opioid therapy should not be discontinued abruptly, and clinicians should not abruptly or rapidly reduce opioid dosages. That part's good, at least. So Solom says, these warnings are welcome if overdue, but it's not really clear what working with patients means. That's just the kind of, politispeak that they always seem to engage in. And then they have a caveat that they've underlined, the CDC underlined this, not reason. They're just passing along the underlining. The recommendations related to opioid dosages are not intended to be used as an inflexible, rigid standard of care. Rather, they are intended to be guideposts to help inform clinician-patient decision-making. The problem is they're bad guideposts, but whatever. Further, these recommendations apply specifically to starting opioids or to increasing opioid dosages, and a different set of benefits and risks applies to reducing opioid dosages. And the CDC acknowledges the concern that advice tied to specific dosages might lead to suboptimal care and misguided policies. Gotta love that word, suboptimal. As opposed to disastrous, as it is for so many pain patients, so. Alright, we got Lynn Webster, former president of the American Academy of Pain Medicine. The CDC does not acknowledge the weak scientific basis for MME thresholds, which do not take into account wide variation in how patients metabolize and respond to pain medication. The CDC clearly prefers that doctors treat pain with something other than opioids whenever that is feasible, but it acknowledges that NSAIDs such as ibuprofen also carry risks and may not provide adequate relief. And while its discussion of non-pharmaceutical treatments may strike pain specialists as excessively optimistic, it does not insist that patients try every other conceivable option before opioids. Yeah, I mean, you do want the non-pharmaceutical stuff. You want to attack this from multiple directions. So, if something like a heating pad will help, it helps me sometimes to put a heating pad on. Yeah, then you do that. You try this from every possible action. But, I don't see how you can do it without opioids. I take NSAIDs too. I take naproxen. I just take the over-the-counter amount. It's not a big prescribed amount. And I take that twice a day, and it helps. And I found out how much it helped when I got my colonoscopy, and I couldn't take them for 24 hours beforehand. Yeah, if you remove any one part of your pain management regimen, it can be disastrous. But opioids are so crucial to this. It's just really, really terrible that they're still continuing to say things like this next part. Opioids should not be considered first-line or routine therapy for subacute or chronic pain. I'm going to disagree with that. They're the only real painkillers we have. NSAIDs work, by reducing inflammation. Gabapentin works, by reducing neural activity, and that can, reduce neuropathic pain. It's actually epilepsy medicine, so. But that's all indirect. Opioids are the only ones we have that work directly on our pain, so. But at least they say, this does not mean that patients should be required to sequentially fail non-pharmacologic and non-opioid pharmacologic therapy or be required to use any specific therapy before proceeding to opioid therapy. The problem never was, oh, you had surgery, oh, you had an accident, here, have some opioids. That was never the problem. That was never, ever, ever, ever the problem. And the data sings that. The data sings the truth of that statement. And so then you've got all these time limits, the expected duration. Oh, they're not limits, it's just an expected duration. A patient taking hydrocodone after an injury or surgery, for example, may find that he is still in pain after his pills run out. The CDC is so keen to avoid the risk that unused pills will be diverted to non-medical use that it is willing to let such patients suffer until they manage to get another prescription. And the CDC says, clinicians, practices, and health systems should have mechanisms in place to provide timely reevaluation for the subset of patients who experience severe acute pain that continues longer than the expected duration. But as Solom says, this seems an awful lot like wishful thinking. Even with mechanisms in place, patients will suffer from unrelieved pain while they're jumping through these hoops. There is an unacknowledged value judgment here that says the war on drugs takes precedence over patient welfare. Likewise, with the CDC's position that opioids are not first-line therapy for patients recovering from dental surgery, the aim here is to prevent unnecessary prescriptions that might contribute to opioid misuse. But pursuing that goal means that many dental patients who find that Tylenol and Advil are inadequate will just have to suck it up. The CDC's bias against opioids does not seem to be justified by the addiction risk it emphasizes. I think this is similar to the studies we've covered before. 2015, 100 million Americans use prescription opioids, including non-medical users as well as bona fide patients. About 2 million of them, slightly more than 2%, qualified for a diagnosis of substance use disorder, which subsumes both what used to be known as substance abuse and the more severe substance dependence. By comparison, data from the same survey indicate that 9% of past-year drinkers had an alcohol use disorder in 2015. As for fatal overdoses, 2015 study of opioid-related deaths in North Carolina reported in Pain Medicine, found 478 fatalities among 2.2 million residents who were prescribed opioids in 2010. I'm one of those. And in case you haven't noticed, I did not die from an overdose. I think I would have noticed that. An annual rate of 0.022%. Prescription opioids are not the problem. But Webster notes that the CDC dubiously blames opioid prescribing for increases in drug-related deaths between 1999 and 2010, without acknowledging that the upward trend in fatalities accelerated after the government succeeded in reducing the use of opioid pain medication. I've shown the data on this. I'm putting this in a playlist I have of a whole bunch of videos about the so-called opioid epidemic and all of that. Look through that playlist. You'll see all this data. As opioid prescriptions fell, opioid-related deaths, primarily involving heroin and illicit fentanyl, rose to record levels. It's really the fentanyl. The heroin, if I remember the data properly, actually went down. And that was after Obama moved opioids over to Schedule 2. Drug warrior Obama. Even when the CDC concedes that opioids are necessary, that message may be lost amid all its warnings about the dangers of these drugs. And the New York Times reports that the guidelines advise against prescribing opioids except for traumatic injuries such as burns and auto accidents. If Times Health Law reporter Jan Hoffman got that impression, clinicians might as well, leading to further misapplication of the CDC's advice. So we also have Kate Nicholson, president of the National Pain Advocacy Center, who says that the remaining references to MME thresholds are not adequately justified and could still be lifted by policymakers. She also suggests that expanding the guidelines to cover shorter-term pain opens a can of worms and may confuse more than clarify. While a lot has improved, a lot still needs to be addressed. Then there's Bob Twillman, former executive director of the Academy of Integrative Pain Management. He says, in particular, the elimination of specific dosage numbers is welcomed because those were very easy for policymakers and payers to latch onto in setting policies. While it's good that they're removing those, I fear that it's a bit like closing the barn door after the horse has escaped. There's a lot of work that needs to be done to modify or eliminate policies that were tied to the specific numbers in the 2016 guideline, and I'd like to see CDC play a role in that work. And this last part here is going back to Webster. The good thing is that the explicit dose limits were removed and the days of opioid supply for acute pain are not specific. But although they say that the guidelines should not be an inflexible standard of care imposed on specific populations, they do not expressly state that law enforcement and policymakers should not use them to set a standard of care or to prosecute providers, because that's what they've been doing. And we've seen that, oh, you've been prescribing this person more than this completely arbitrary amount that isn't backed up by any science or research. Well, we're arresting you, we're taking your medical license away. Yeah, that's a huge problem. And it stems from the CDC. From the fact that the CDC does not follow the science. And so Webster questions why the CDC felt a need to advise doctors about pain treatment in the first place. That function should be left to professional organizations. Several experts in the field predicted the outcome of the 2016 CDC guidelines before they were issued. The debacle with the 2016 CDC guidelines illustrates the reason the CDC should not be imposing their views on how pain medicine should be practiced. Yep, they're still going to do it. They are. As long as they've got their wonderful war on drugs, and as long as they have scapegoats that they can point to, and us pain patients are great for that, then they're going to continue to do it. And it's like I pointed out in a fairly recent episode of the podcast. It's like, on the one hand, they want to blame pain patients for everything. On the other hand, they're acting like illicitly manufactured fentanyl is just the worst thing ever. You have all of these really dramatic policeman going, "Oh no, I touched fentanyl powder. I'm having an overdose. Oh no, I breathed in some fentanyl odors. I'm having an overdose," when it doesn't work that way at all. And yet they don't see the incongruity there. They don't seem to see the contradiction in saying that the illicitly manufactured fentanyl is like the most dangerous substance on the planet, which, I mean, if you can get an overdose just through contact with the skin, then why do they bother injecting it, you know? Am I right? But between that and pain patients, prescription opioids, doctors and pain patients are responsible for all of this. Well, it can't be both. Can't be both. But they'll make it out to be. That's what they do. Because actually trying to solve the problem just might admit that their authoritarian tactics don't do any good, and they'll have to give up their power to actual people, actual patients, actual doctors, people who are actually in a position to solve the problem. And as long as that's not them, then they're not going to have anything to do with it. But hopefully this is a tiny step in the right direction. Maybe they'll keep chipping away at this. You know, it really should just be cut off entirely, but I don't know. I guess we'll have to take what we can get. Thank you so very much. Comments for the Common God, shares for the Share Throne. Hit like, subscribe, the bell. Go to donate.bogosity.tv to keep me doing what I do. Keep this channel going if you like my videos, especially if you like watching them over and over again and following me throughout time. Considering going to Patreon and Subscribestar, you can become a regular supporter, get these videos early and ad-free, and just get the benefits. You can join in the live streams. There's a special area of the Discord and things like that. So I hope to see you there, and I hope to see you next time. Until then, stay strong and be free.